pleased to bring to you our second installment of Community Conversations. One of the things that we felt was an important venue was to reach out to the public to provide educational opportunities, and we thought what a great place is to bring people in here. So along with Don Roden and myself, we're trying to come up with a calendar for Community Conversations, and tonight's topic is maintaining a healthy heart. I do have next month's topic already. We're actually going to have two topics in the month of March. The first one's on concussions in youth sports, a very important topic, and we have the athletic trainers at Meadville Medical Center and Dr. Teresa Wheeling talking about that. And then 2 weeks after that, on March the 24th, we are having the dietitians and, fingers crossed, along with Dr. Gailey, one of our orthopedic surgeons, talking about bone health. So again, we're trying to get relatively informative conversations, not lectures. We want this to be an informal environment, so please, if you have any questions, don't hesitate to ask. But tonight, with regards to maintaining a healthy heart, I'd like to introduce Dr. John Wilson as our Ask the Expert speaker for tonight's community conversation. Dr. Wilson graduated from Penn State a few years ago. He interned in Boston and then did his fellowship in interventional cardiology at Duke University in North Carolina. We are absolutely thrilled when Dr. Wilson and his wife Kelly and your son Dick moved to Meadville around Christmas time or in December of 2012. He's been an amazing addition to our medical staff, and speaking on behalf of someone that I hold near and dear, who's benefited from Dr. Wilson's care. So thank you all for coming, and Dr. Wilson.
Thanks. So this is going to be casual, okay? It's whatever you guys want to talk about. I have a few things that I'll say up front. What we wanted to talk about is how to keep a happy, healthy heart. But one of the things I did want to talk about first was how your heart doesn't get so happy. And some of those we can control, some of them we can't. I'm going to talk just real briefly about what happens to the heart over time. The heart is simple. It's interesting. The orthopedic people joke with us and say, I have to deal with 100 different muscles. You have one. I have the heart. That's all I do. It's one muscle. Pretty important though. It feeds all the other muscles. But that's all the heart is. It's a muscle. It's a muscle supplied by plumbing and electrical. Very, very simple. But ultimately, everybody dies because their heart stops. Everybody dies because they have a cardiac arrest. We need to prevent that. Prolong life, we need to do things that we feel like we should be doing. And I'm not God. I'm I have my hands, I do what I do, and we all live through life and prolong, hopefully, a good life for people. So, a couple things I want to talk about. First, risk factors for coronary disease. Some of them we can deal with, some of them we can't. Right off the bat, if you have heart disease in your family, you pick the wrong family. You can't fix that. Someday you can. Gene therapy is going to fix that. But we can't fix that. So heart disease at a young age, I always ask patients or people, anybody in your family with heart attacks, stents, bypass, 40s, 50s, 60s. And it depends a little bit on if you're male or female when you had that happen in the family, but I'm not going to get into the details of is it 45, 50, 55. Generally, if somebody in your family had a heart attack in their 70s and above, that's just life. That doesn't mean you're at risk of having that. But if you had a brother that had a heart attack when he was 40, or a sister that had a heart attack even that age or even a little later, that's significant. So we can't change genetics. It is what it is. Other things, the classic things, smoking. The one thing you can do something about, the one thing that causes incredible injury to the walls of the arteries is smoking. nicotine, not just smoking, but tobacco in general. Even chewed tobacco does the same stuff, it just doesn't hurt the lungs. So smoking is one of the things we can fix. Diabetes, people get afflicted with diabetes. Okay, we deal with that. Diabetes is tough on the blood vessels. Very tough on the blood vessels in the heart and the rest of the body. So that's one of the things that is a big, big risk factor. High blood pressure, why? It just pounds the arteries, causes damage to the inner wall of the artery. Now you can start to form plaque inside the artery. Plaque is not the same as on your teeth. Plaque is cholesterol buildup that we'll talk about in a second. So hypertension is one of those things that can increase your risk, of course. I always tell patients, people, myself, my dad, my brothers, my wife, hypertension is only bad if you have hypertension. So if you can bring the blood pressure down, you've taken away that risk factor. Not so much with diabetes. We do know if we can control the sugar, we bring the risk down, and we have to do that, and it's very important. But that's a lifelong process. Just like coronary disease, once you have plaque buildup, it is not. It's a lifelong disease. It's not curable at this point. Okay, we can slow it down. We can stop it in some cases. We can't necessarily reverse it. You start developing plaque very early in the arteries. They've done, unfortunately, autopsy studies in people in their teens that had car crashes and things. And even teenagers start developing these fatty streaks in the aorta, where you have cholesterol starting to build up, even in your teens and 20s. And that's the precursor of coronary disease. So all those things are risk factors. They start early. When you start worrying about cholesterol at age 50, it might be a little late. So I think we're more aggressive at looking at cholesterol and things like that. So cholesterol is another risk factor. Obviously, high cholesterol. But it's interesting that about 30 to 50% of people that have the big heart attack that come in have cholesterols less than 200. So it's not just about the numbers. It's about what your body does with the cholesterol and where it puts the cholesterol and how it gets there. Some other lesser known risk factors, but things that we can't measure. Stress. Okay? Stress. I can't measure your stress, my stress, your stress. You can't measure stress. I can measure blood pressure, how many cigarettes you smoke, what your cholesterol is, what your A1C is. I can measure all that stuff. I can't measure stress. Okay, so stress is felt to be a contributor. It's easy for me in the office to say to somebody, well, just don't worry about it. I don't say that because I know that doesn't work. Stress is real. And so stress is one of the risk factors for coronary disease. In fact, the most common time to have a heart attack is Monday morning, between 6 and 12. Okay? Why is that? Your body's revving up, getting ready to go to work. All of a sudden your adrenal glands put out epinephrine, which is adrenaline. Put out glucocorticoid steroids, basically, is what your adrenal glands put out, get you ready for the day. And Monday mornings, of course, if that's your work week, is a bad time. And then you put in a little snow shoveling in there. Get your car out on a Monday morning, and there you have, yes, ma'am.
We know a retired person that had his heart attack Monday morning, and he wouldn't be going to work. Is there any reason why somebody that's retired would have a heart attack Monday morning?
Monday mornings, we don't know. I mean, it's chance. 1 in 7 days it's going to happen. But that is the most common time to have a heart attack. Has nothing to do with Mondays. I think full moons have a lot to do with everything. I never know there's a full moon until I have a really, really bad day and night, and then I look up and I'm like, oh, it's a full moon. So that's where I do the opposite. I never track the full moon. But there's a lot of things that go into it, and I don't know exactly how to answer that, but the point is that the higher stress situations produce high blood pressure. They produce the heart pounding against arteries. Now you can cause a problem inside the vasculature that can cause a heart attack. And when we talk about the vessels around the heart, I don't even have anything close to the size, but if you took a pen in your pocket apart, the little tubing inside the pen, That's about as big as the arteries are around your heart. Maybe just a little bigger than that with some people. So it doesn't take a whole lot to mess up the plumbing to the muscle that provides everything to the body. So those are some of the things that can lead to badness. Stress I talked about. Obesity is another one. Obesity is interesting because obesity leads to higher cholesterols. It leads to hypertension. It leads to diabetes. So we don't know if obesity in and of itself is a risk factor because it draws everything else in. So again, you can't measure necessarily obesity in any one person and whether or not it's a risk factor, but it goes along with coronary disease for obvious reasons because it brings in 3 of the big risk factors, which is cholesterol, high blood pressure, and diabetes. And then, of course, I talked about smoking. So those are the main risk factors that we deal with. What happens is when all those things start pounding the arteries, you start forming cholesterol in the walls of the arteries. You start depositing cholesterol. And for a time, the vessels do okay with that. The vessels actually expand. So when we do a heart cath on somebody and we inject dye down the artery, we can say everything looks clean, looks fine. That artery may have expanded with cholesterol buildup to keep the central channel open. Okay, your plumbing at home doesn't do that. Your plumbing just clogs. This is elastic. It can expand, and to a point, it does that. And it's called remodeling, and positive remodeling, where the vessel expands. After that happens to a certain point, it can't expand anymore, and you start getting encroachment just like you do in the pipes at home. So that's what happens. Now, in the wall of the vessel, the cholesterol is irritating to the blood vessel. Okay? So white blood cells come in. White blood cells fight infections. They're very aggressive at doing things. White blood cells start putting out what are called metalloproteinases. It's a big term. It basically is an enzyme that starts dissolving the inner lining of the blood vessel. And when these metalloproteinases come in and you dissolve the inner lining, all of a sudden that plaque ruptures. And the way I like to describe it, it's like a kernel of popcorn in the wall of the arteries, just sitting there, all of a sudden, boom, it's taken up space, and your body tries to heal that. Your body has no idea what just happened there, and the main thing that your blood vessels or your blood cells do is to try to prevent you from bleeding to death. So they don't know if that rupture came from the outside in, like a shave, or the inside out to put the blood clot there. Okay? So that's what causes heart attacks. That's what causes unstable symptoms. It's not the same thing as somebody just building up a plaque over time. Now I'm getting more chest pain, shorter breath, treadmill's abnormal, whatever. These are people that come in, all of a sudden we're doing fine, and boom, I had a heart attack, and a little different story. But that's what cholesterol does in the walls of the blood vessel. And so we have ways of decreasing that inflammation, decreasing those white blood cells from doing their bad stuff in the wall of the blood vessel. So, you have a question?
What about people who have low blood pressure? Like I know somebody that had 96 over 45.
So low blood pressure isn't associated necessarily with heart disease. Sometimes we do that with medications. We overdo things. I'm a heart guy. Okay? I want your blood pressure through the floor. Because that means nothing's being stressed. So if you're 90 over 60 and you're not getting dizzy, lightheaded, passing out, your heart's working very efficiently. It does not have to squeeze against high blood pressure. So that's why exercise and other things that we'll talk about, exercise basically allows your muscles to get more efficient. So the muscles now don't need as much oxygen and the blood pressure stays lower. And so you have less resistance to flow out of the heart. It's very simple. If the heart doesn't have to squeeze hard, it doesn't use a whole lot of energy. And the energy that the heart uses is, the same thing that we eat every day. It's, it's carbohydrates, it's fats, it's proteins. That's what the heart uses. We can go in excess one way or the other, and we can talk about that But that's basically why we want to keep blood pressure low, cholesterol low. We want to do everything we can to improve the system, if you will. So does that mean everybody in this room has to get out there and jog 100 times a week and 6 hours a day and get out there? And it's been kind of interesting. I just wanted to show on this board a couple of things. I can actually use the same, because I'm not a very good artist. But all I'm going to show you is one thing, and then you'll see what I'm talking about. That's my art. It's not a tongue. It's nothing. Moderation is what we're talking about for most of the things we're talking about. So going crazy about reducing your salt intake. Okay, I'll start with that as an example. If you have heart failure, weak heart muscle, there's a problem, you have swelling, you have reason because the heart can't keep up with the squeezing, then yes, we want to restrict the sodium. So the levels at which we're told to reduce sodium, I'm just going to say 2 grams here. Okay? The bad American diet is here. 10 grams of sodium. If you drink a 12-ounce can or a 12-ounce thing of tomato juice, you've already hit this for the day. Okay? So 2 grams of sodium is pretty tough to stick to. This is somewhere around 3 to 5 there. Okay? If you look at mortality, patients dying, patients do the best at this. People do the best at this. The American Heart Association says we should all be doing this, and the people that are over here overdoing it, it's the same. So moderation, okay? I'm not saying don't eat low salt, because it depends on the situation. If you have high blood pressure, sometimes people are very, very sensitive to sodium, so you need to have a low sodium diet. But what I'm trying to show you is that the lowest is not always the best, okay? Does that make sense? If you start looking at things like, you guys, you two in the back will hate me for this one. There was a study that came out yesterday in out of Copenhagen for exercise. Okay, it basically said if you do 0, you're here. If you do very strenuous, you're here. And if you do moderate exercise, you're here. The lowest mortality is in moderate exercise. This is jogging. Okay, this is an interesting finding, and it's not controlled. Wasn't randomized. It was just basically an observational trial. But again, moderation is the key. You don't have to get out there and jog 15 miles a week. You have to just do something. Okay. The American Heart Association (ACC) right now is basically saying that the recommended amount of exercise is 30 to 60 minutes of exercise 5 days a week, and 7 days would be even better. That's very different than what I used to tell people, 20 minutes a day, 3 days a week. That's all you need. The key here is the strenuous part. This is fast jogging versus maybe the same amount of distance at moderate or slow jogging. It's very interesting. So I don't even know what to make of this. This popped across my desk last night, and I was reading the trial today, and it's observational, but it tells me again, it's moderation. Okay? Same thing with salt intake. Same thing with just doing stuff. Don't go crazy one end, the other end. Do something. Do something, routinely. And you end up in this category of the lowest mortality. So, the pendulum in cardiovascular medicine, as you guys, I'm sure, are aware, just goes back and forth. Everybody should be on niacin. Nobody should be on niacin. Everybody should be on niacin. It just goes back and forth. And so I think we have to be a little bit curious about trials like I just told you about, this one. But it makes sense that at least some moderate exercise for most people is going to keep your heart healthy. It just is it. It does exactly what I said. It just is it. It does exactly exactly what I said. Keeps your muscles healthy, less strain on the heart. Heart doesn't have to use as much oxygen. Even if you have blockages, it actually treats the heart muscle. Okay? So that's sort of my start into this. This is meant to be sort of a throw it out there. What do you got? I know a guy that has a sick heart. You have a sick heart. You don't have a sick heart. How do I keep my heart healthy? Should I eat more turnips? Anything. I don't know. I would eat less turnips. So, in general, so. Brussels sprouts. So I don't know if there's any questions. I can talk all night long, and I will if we, but sure.
So does the exercise help the heart? Helps the heart muscle? Does it also help with regression of the blockage?
So that's a very interesting concept, is regression of coronary disease. And the problem we have with regression is that the classic literature out there was Dean Ornish, the Dean Ornish diet. You guys familiar with it? If it tastes good, spit it out. It's cardboard. Just eat cardboard and you'll be okay. And do that for the rest of your life. And you'll live a long, happy life, except you might not. So have a miserable life and just eat cardboard. So that's the Dean Ornish. And the nice thing about it, it was a great diet, a very Mediterranean diet. It's still around. There's Dean Ornish Center still around with exercise. It's not just the diet. But the issue was when they looked at progression of disease versus regression of disease, they basically were looking down the corners and saying, yes, with the Dean Ornish diet, we caused regression. Okay? So we could actually reduce the plaque burden with that diet. The problem is, if you looked at deep into the statistics, the right coronary artery might get worse, but the two on the left got better, so statistically you got better. So you had one artery that actually needed to be treated down the road, but two other ones got better. So it's very hard when you look at these trials, exercise, to really say that regression is across the board, across lesions. We don't understand why certain blockages get angry, other ones don't. I always tell people that when they come to us, it's kind of like going to a dentist. Sometimes you need something done, sometimes you don't, and it's nothing that you're doing wrong. You're doing everything the right way, but we can't predict how a blockage that's 50% today can turn into a heart attack tonight with that rupture that I talked about. So in general, there are exercise trials that have shown regression. There are diet trials with exercise that have shown regression. How you measure regression in an individual patient is easy, but across 1,000 patients in a trial where it says, yeah, we can show regression, but a third of the lesions actually got worse, 2/3 got better, and we got statistical evidence that says we can regress lesions. That's the problem, is that it's very lesion dependent. And so, but in general, yes, exercise can do that too. Yes?
Talk to us about statins, particularly the risk versus benefits.
You just start me up now.
Let me finish, because I really have a question about, is there a time when they've had enough, like, in older age? And if so, what age?
Okay, so people think I'm crazy when I have a 9-year-old that comes in with a heart attack and I put him on a statin, okay? They think, what are you doing? This is 90 years of damage. What are you doing? Remember I talked about inflammation in the walls of the vessels. And I'm not going to go on a statin rampage. I'm just going to give you my spiel on statins, and I'll show you something I think is kind of interesting. Statins, in general, half of what they do is prevent your liver from making too much cholesterol. Okay, that's how they were thought to work initially. They're the most potent things for reducing cholesterol, the bad cholesterol. There are side effects to statins. We talk about that. There's issues with, cost isn't as much of an issue, nearly as much of an issue as it used to be with the statins. But statins basically do another thing, and they reduce those white blood cells from causing inflammation. They reduce plaque rupture. 2 types of heart attacks that we see. One is a progressive narrowing, okay, and then you form a blood clot on it. One is a somebody who says, I was just in your office last week, I had a normal stress test, I had a normal EKG, how could I have had a heart attack a week later? Because nothing showed up because you had a 50% blockage. That 50% blockage had a very thin capsule on top of the plaque that was there. The inflammation ruptured the plaque. Now you had the big heart attack. Statins reduce inflammation, stabilize plaque. Can reduce progression of plaque, can actually decrease the size of the plaque. But again, some plaques get bigger, some plaques get less. I'm not saying statins are the only answer. But statins reduce inflammation, and we've seen in, not just here, but across the country, that the number of what are called STEMIs, the big heart attacks, I just closed off a vessel in the ER having a big one, have been reduced. Much more dramatically than we would have expected from just general care. And people are getting older, we're treating older patients. And most people think it's because of statins, early statin use for cholesterol, which prevents the big heart attack. Okay? We can talk about the bad side of statins in a second. Just bear with me for 1 minute, and this will kind of tell you what the deal is on the statins. So every time a clinical trial has been done in the past where people used statins versus placebo, you can imagine the patients that were, if this is cholesterol over here, over time, patients on drug did that, okay? Cholesterol went down, okay? Patients on placebo, where do you think that went? No, went down. Why did it go down? You're motivated, you're in a trial, you're exercising more, you think you're on the right drug, you're on a placebo, you have no idea. So this is the problem with clinical trials, is you have people now that are altering the outcomes. The placebo has nothing to do with that. It's because you're motivated, you're in a clinical trial. That's who goes into trials, goes every 3 months to see somebody, gets their blood drawn, stays in it for 3 years, Framingham trial. Some of these patients have been in 20, 30, 40 years getting their blood drawn, doing all this. So they started measuring something called a C-reactive protein. And C-reactive protein is a measure of inflammation in the body. And as long as you don't have a urinary tract infection, gout, something else going on that's causing inflammation, it's a pretty good judge of what's going on inside the arteries. Okay? So what they did was they measured CRP. I'll just do that in a different way. So CRP, if you were on treatment, as you can imagine, CRP went down. Okay? This is because statins reduce inflammation in the walls of the vessels. What happened in the patients that their cholesterol still went down, that weren't on a statin? CRPs went like that. So over 3 years, you started seeing more inflammation in the walls of the vessels. You were still putting cholesterol into the walls of the vessels despite the number going down. So it's not all about the numbers. It's about how you deal with the cholesterol that you have. And if the cholesterol is there and you can reduce the chances of it causing a problem inside the wall of the vessel, your event rates go down, your cholesterol goes down. So this was a very, very interesting finding. Initially it was something called Pravachol or Pravastatin. It was one of the first statins out there. Navicor, Pravachol was close behind that. Zocor, they all came out roughly the same time. Navicor was the first one. So it's just telling you that no matter what I'm doing to lower cholesterol, and again, you can use your garlic, your red yeast rice, you can use anything to lower cholesterol. It doesn't mean you're preventing progression of disease. You have a number that you're looking at, not necessarily what's going on. So, sir?
So in these studies, the placebo group, with their CRP going up, did they show a greater incidence of heart attacks?
So what happened with these trials is that, yes, over time, if you were on a statin versus no statin, you reduced your event rate. And most of the trials were like 5-year trials. Okay? The issue was when they went back to look at these orange lines, was after the trial was over, they saved the blood from these people and basically spun the blood back down and said, hey, now we have a new test, let's look and see what actually happened. That's what was intriguing about this, was to say it all made sense in the fact that these people actually did better on statins. Does everybody need to be on a statin? I'm not suggesting that. But the data is very clear what statins do and then why you should be on a statin. Now, I'm not real happy about what happened a year and a half ago or so with the new guidelines for cholesterol, okay? So we're all used to measuring cholesterol and LDLs and where we should get our levels, and if you didn't have significant risk factors, you wanted your LDL, your bad cholesterol, 130 or less, but we wouldn't treat until it was 160. It's hard for somebody to walk in my office with an LDL of 160 that I don't want to treat. But you have to step back and say, why is the patient here? Most of my patients are secondary prevention. They already had a problem. So I'm in a whole different boat than the primary care physicians, where they're trying to figure out who to use statins and who not to use them. So what happened was, then it was, we want the LDL less than 100 if you have heart disease. And then if you're diabetic, now we want less than 70. So there's this whole push to ramp up the statins to get your levels down to below 70. In the midst of that, now they've come out with new guidelines that say, we don't really care about the absolute number. If you were this person with these risk factors, we want you to reduce your LDL by 50%. Well, I'm in a place where I have no idea where people started. They're already on statins. I don't even know where to go with that. If your LDL is 100, was that half of what it was 3 years ago? I don't know. I have no idea. And maybe we didn't even measure it 3 years ago. You got to put on a statin. So I think that it's very short-sighted. Now, it's easy for me because if you have heart disease, you need to be on the highest dose statin of either Lipitor or Crestor. So they made it simple for me. It's not so simple. People don't tolerate the highest doses of the statins. They get side effects from them. And they were teaching us 3 or 4 or 5 years ago that going from 40 to 80 of Lipitor, you were doing a minuscule amount to reduce cholesterol, so why do it? You're just getting more side effects. Now they're saying everybody should be on 80 to start. So I don't buy that. I'm sort of in between with the numbers and with the dosing and who needs statins. The AHA, American Heart Association, American College of Cardiology still say if you have coronary disease, we don't care where your cholesterol levels are, you should be on high-dose statin. That's the national recommendation. Is it right? I don't know. But that's the national recommendation.
What's your opinion of the difference between measuring absolute numbers, total cholesterol, LDL, HDL, versus ratios?
So there's a couple things there. Ratios, when you start looking at good cholesterol, bad cholesterol, so you're looking at HDL, LDL cholesterol ratios, total cholesterol, there's something called, let me back up a second. There's actually a blood test that can be done now. It's called a vertical profile, or a VAP, that's done. It actually looks at all your different particles to figure out whether or not your HDL level, which is 60, which is awesome, is actually good HDL. Because some of that HDL might not be so good. And so when I've used the VAP profile, and again, I don't use it often because I'm already treating people that had heart attacks. It's a little different look than somebody who's never had a heart problem before. But when you start looking at that VAP, you start seeing, wow, I thought that HDL was actually protective, and it's not. So when you start looking at ratios, you're assuming that your good and your bad are what they're supposed to be. Sometimes the bad ain't so bad, and the good ain't so good. So the ratio doesn't really matter. I'm not trying to confuse things here, but I'm just saying that in a general population, looking at a 50,000 patient trial, ratios are helpful, but in an individual, when you start looking at the minute details of what your cholesterol profile is, and the reason I say that is because certain drugs, if you start looking at little particles, ApoA and some of the other things that have come out, are not treated with the statins. The statins don't work on them. Okay, they will lower your LDL level, but they don't treat those things. Exercise, niacin, which is hit the pendulum the other way, don't use it, doesn't work.
It works.
No, I know it works. But what I'm saying is, in the general population, if you're just trying to raise HDL with niacin, it doesn't necessarily cause statistical significance, so everybody says it doesn't work. Well, in the individual that has low, or high ApoA, it's going to reduce that, and in specialty care for that individual, it may make a difference. So it's a long-winded answer to, should everybody get a VAP? I don't know. I mean, if you have coronary disease, yes, we're going to treat you with a statin anyway. Is there something else sitting there if you're 40 years old and you had an MI? Yeah, I'm going to start looking at other things. And it's just a one-time test. And insurance pays for it. You get it one time, you know where you're sitting and whether or not you have effective HDL particles and LDL particles. Now they're looking at, I just saw something that came out last week too, that looking at HDL and breaking it down, if it's holding on to really heavy, bad stuff, it can't do its job. So you're still measuring HDL, but it's all loaded down with junk, and I can't get rid of it. So now there's a whole other move at looking at what the HDL is already loaded at. HDL, the good cholesterol, is at least simplistically, takes the bad cholesterol out of the walls of the vessels and takes it to the liver and gets rid of it. But HDL is a very complex molecule. There's some good, there's some bad, there's overloaded. This whole garbage truck, it ran out of gas, I can't get rid of it. Or I don't have a dump to put it in, essentially. So it's very, very complicated cholesterol stuff. And I think if you're a younger patient, family histories, things like that, that VAP is a very important thing for us to try to figure out, are we doing the right thing with not treating you with things like niacin. So. Somebody else, somebody had a hand up over here. Yes, sir.
So you talk about moderate exercise. Can you define that in terms of heart rate? I mean, it's a very easy thing to do today, right? You can get an app on your smartphone,
Yeah.
You can follow your heart rate. If you walk slowly and your heart rate never goes up, if you really exercise.
Yeah, so the trial that I was speaking of is it's a little complicated, and I actually I had it sitting in my car because I wanted to bring it in to actually show you specifically, because I knew you would be thinking about this. No, I'm just saying, because of levels of exercise. And the way they broke it down was either hours per week that you exercised, the level that you actually exercise, and these were runners, these were joggers, slow joggers, medium joggers, fast joggers, and then it defined it into, did you do your jogging strenuously? So did you do it in moderately? So I only jogged a half an hour today, but I sprinted the whole time. Those were the people that tended to do the worst. The sprinters, really going at it, and then 4 hours a week, 5 hours a week of really strenuous activity. The 2.5 hours a week at moderate to mild, and we're talking about jogging again, but and they didn't talk about heart rates, I'll be honest with you, with that particular trial. Just in general, you guys probably know this, but 220 minus your age, if I put you on a treadmill and you could do a treadmill, 220 minus your age is the fastest your heart could ever get to, okay, with strenuous activity, 220 minus your age. So then when we look at a stress test, we want 85% of that 220 minus your age is what we're looking for to say that is a maximal stress test, to say it's a good stress test. Now we know that we're seeing the whole heart. People that exercise, we don't want them at 85%. You're not going to last there very long. You achieve what's called your aerobic threshold or anaerobic threshold, where all of a sudden your muscles are creating lactic acid, you're cramping up, you vasodilate, your blood pressure drops, you feel like crap, you pass out. You don't like that, especially on a stress test. But that's why people that run marathons and half marathons and things that they haven't trained for, why they just fall apart even 50 feet from the finish line, because they've reached that level where their muscle just can't do it anymore and their blood pressure drops out. So your question's a good one. I'm not trying to skirt around the idea of what is good exercise. I don't even know the answer. I still think 20 to 30 minutes of getting your heart rate up to 60%, 70% of your maximum predicted, consistent. People are all about weight loss, looking at these interval training and go fast and slow down, go fast and slow down. So I have no idea. Yeah, so your question's a good one. I'm not trying to skirt around the idea of what is good exercise, I don't even know the answer. I still think 20 to 30 minutes of getting your heart rate up to 60%, 70% of your maximum predicted, consistent. People are all, about weight loss, looking at these interval training and go fast and slow down, go fast and slow down. I have no idea. Yeah, it works to lose weight. I have no idea what it does for, I think the slow, steady, slow and steady, moderate, do your stuff, do it consistently, is going to get your heart protection where it needs to be because it trains the muscles. Whether or not you lose weight with it, that's a whole different story about interval training and muscle training and all that stuff.
As far as maximum heart rate goes, like when you're exercising, is there, in addition to this calculation 220 minus your age, that takes into account your resting heart rate? I mean, somebody that starts out at 50, if they get to 100, that's pretty good. But if you're at 80 beats per minute,
that's a good question. I'm not going to say I don't know the answer to that. That's a good question. And we actually, unfortunately, in our population, we mitigate where your heart rate can go with some of the medications we use. We're putting a governor on the engine. It's basically everybody who's ever rented a U-Haul truck and goes out on the interstate, tries to go over 55, it just stops at different round. That's what your heart rate's doing when you're on a beta blocker, for instance. And so a lot of our patients are people on beta blockers for high blood pressure, for heart problems, heart failure, things like that. So we're not artificially, we're absolutely controlling what your heart rate can do. And so you might start at 50, you may never get to 100. Those kinds of people, if you really push it, you're going to feel that because your body's saying, my God, I need more heart rate. And it's not getting there, and all of a sudden the legs start burning, the blood pressure drops. So you're going to get to that point a little sooner. And I don't know what to tell you about training of the heart with a low heart rate. It's a great question, and I'd be happy to look into that. But it's a very good question. I've never heard anybody even ask that before, but it's interesting. We will put people occasionally on a treadmill to make sure their heart rates can get up, especially if they're dizzy, lightheaded, you don't know why they're passing out, to make sure they're what's called chronotropically competent, meaning that they can get their heart rate up. Chronotropic means fast heart rate, or getting the heart rate up over time. So it's a good question. Athletes that run in the 40s seem to have pretty good competence and also health. So low heart rate isn't a bad thing, but normally we don't see people who have heart rates in the 40s and 50s resting. They can't get them up to what they should get up unless we're holding back or you have some electrical issue with the heart.
so if you have a 30-year-old with a resting heart rate of 40, they can get up to like 180, 190.
They should be able to.
Easily.
Yeah, they should be able to. I was telling, Karen's our physician assistant in our office, Karen Hunts, so if you guys haven't met her before, but we were talking today about this. I generally run a pretty low heart rate, at least when I was younger and healthier. And they put me on a treadmill when I was a fellow at Duke and did the whole thing, closing off the nose, measuring the oxygen, and painful. And I went, close to 20 minutes on a Bruce protocol, which about killed me. And I got my heart rate to 200. And 220 minus my age at that point was 180, 185. And so, yeah, you can push it. You'll get it there. But it's just you don't have to be there daily because your muscles don't need it. You're trained. You have trained muscles. And that's what activity does for your heart. It doesn't improve your heart function necessarily. It just makes your heart's life easier. It doesn't have to get the oxygen places it doesn't need to. You have a very efficient system, so you don't need as much oxygen or blood pressure to get it there. So that's what, if you have a heart muscle where the squeezing function is half of what it should be, I can't get it any better with exercise, but I can get you feeling a whole lot better with exercise because your heart muscle is just a muscle. And if it doesn't have to squeeze hard, it's fine. It's love and life, and because your muscles are taken care of. You can train other muscles. You can't train your heart necessarily. if you've had heart damage. You can't train the heart muscle to get better. We have medications that can help that, but you can't make your heart muscle stronger with exercise necessarily. It makes it more efficient, so it essentially is stronger, but that's what it's doing. The number may stay exactly the same, the squeezing function, but you feel 10 times better because your muscles are able to take it. So. Yes.
What impact does sleep have, or lack of?
More is, some is good, more is better. That's a good one. I think the biggest thing that we see with sleep is not so much the duration of sleep, but the quality of sleep. And so many people, I'm just amazed, and I don't even want to get tested myself for sleep apnea. I'm saying, but you see people with sleep disorders where they don't get into deep REM sleep, and some of it's because they're having, either central sleep apnea or obstructive sleep apnea, where they're not getting into that because all of a sudden the oxygen saturations come down, and then all of a sudden you arouse because you don't have the oxygen, or the carbon dioxide starts building up, and then you sort of come out of a snoring fit, and all of a sudden you just start back again, and you never get into that deep sleep. Well, it's not so much the sleep, but it's what the oxygen decrease is doing on lung function, increasing pulmonary pressures, increasing the chance of sudden cardiac death, things like that. So I don't know the answer, I'll be honest with you, just about plain old sleep. If you have great sleep function and you just don't get it, I don't know. Hey, that's a good question too.
More importantly, is the myth of red wine true?
Is the what? If you like it.
Please say yes.
I hope it is.
All right.
So here.
I'm telling my wife, by the way, it is. Technically curious.
If you don't learn anything tonight, every curve looks like this. This is mortality with no alcohol, this is moderate, and this is high. So you want to be at the bottom part of this wine glass. And wherever you draw your levels to is fine. Yes, red wine.
Dark chocolate too?
In dark chocolate? There's there's a lot of stuff out there, I think, that is not necessarily been medically proven, but some of it has, and the Mediterranean diets and the dark chocolates and the small to moderate red wines versus white wines. There is something. It's been debunked. I'm just blanking completely on the chemical. Resveratrol. So that was supposedly the thing. If you took it, you had the greatest. You could be Moses. 600 years from now. And there was a guy at UPMC that still believes in it, and he runs his marathons in Hawaii and does his and he's a neurosurgeon at UPMC, a guy named Maroon, who believes in this, has a company that sold this to the masses. And I saw a recent trial in the last year that basically said, randomized trial didn't show any difference. Red wine's good though. It gives you peacefulness.
Serenity.
It does help HDL. Again, alcohol in general does help HDL moderate levels. Talking about 1 to 2 glasses, and when my dad comes to town, I hide the big glasses because when he pours his wine, he pours it to the top. That's a half a bottle. Right? So whatever glass we're talking about still moderate levels. 1 to 2 drinks, maybe a day, help HDL. But some people don't even know if it's good HDL. And when you start looking at those VAP profiles, sometimes the HDL goes up and it's not the good stuff. It's just you're masking, feeling good about your ratios. And the ratios aren't necessarily appropriate, so they're not reflective of what's going on in the body. So, good red wine. It's not the cheap stuff. Any other questions, anything? Doesn't have to do with, it could be about bad hearts, electrical problems, anything, nothing, pacemakers, anything.
I have a history of Raynaud's.
Yes.
Is that, I had an incident 10 years ago where I touched a cold in the middle of the winter, and I felt electrical shock, like a doorknob, and it felt like there was ice like in my veins. And I was diagnosed with Dr. McDermott, like basically doing a procedure. I was put on medicine for that winter, and then I was told to go off of it, and I've never had to take it since.
That's interesting. You weren't smoking anything at the time. I mean, right now, it doesn't have to happen with smoking, but it's people are very sensitive to the cold. You get all of a sudden your fingertips turn white, purple, red, all of a sudden, you get reperfusion, and it's from vasospasm. And it's more common in people that smoke, but you don't have to smoke to have it for sure. Whether or not it's related to, some people believe it can be related to birth control, ups and downs of progesterone and estrogen in women. It tends to be more common in women than it is in men. It can come and go. It can come and never be a problem. Some people have such severe problems with it that it's not life-threatening, but it's life-changing. You can't go anywhere without gloves on and we have medications to dilate the arteries, which are the calcium channel blockers typically. Sometimes we use the nitrates, but things like norvascular, amlodipine, diltiazem, verapamil, those are used. And some people that have Raynaud's get coronary vasospasm too. We were talking about that a little bit earlier. Can you get spasm of one of the vessels? And so people that have migraines, Raynaud's, coronary spasm, migraines are from spasm in the arteries in the brain. You get the spasm, you get the funny little things in front of your eyes because and some people can have stroke-like symptoms. All of a sudden your body says, whoa, dilate that. It does, and you get this booming headache that just incapacitates you. So that's a migraine. It can go along with Raynaud's. It can go along with vasospasm. It tends to be more common with the other things, especially the coronary vasospasm, female smokers, which that's not the case. And while you had it, and it went away.
I just wondered if I should be concerned down the road with my heart.
It's not necessarily related to coronary disease or blockages in blood vessels. In fact, most of the time it's not. If you have coronary vasospasm, almost always it's because there's a blockage there that it could be a 20% blockage. But your natural vasodilators, we all produce nitric oxide in the walls of the vessels. There's something called prostacyclin that is in the walls of the vessels. If you take aspirin, it reduces your platelets from making prostacyclin, so you can actually promote vasospasm by taking aspirin. And people that are prone to it with Raynaud's and whatnot, beta blockers can promote Raynaud's. So if you're on any of the beta blockers for any other reason, we usually try to switch you off of those for that. But it usually doesn't correlate so much with coronary disease, especially if it just came and went. I don't know how to explain it, but yes.
Our daughter, she gets severe migraines. Is there anything that you think of that she could do?
Well, migraines are a whole different thing because there are lots of different causes of migraines and treatments for migraines. And whether or not you have the classic migraine, whether or not it really is migraine, it's cluster headaches, there's all different kinds of things that get classified as migraines. The classic migraine is caused by a spasm in an artery in your head that releases, and now you have the pounding head. As far as the heart goes, there's one association. There's a phenomenon where people have a hole in their heart. It's called a patent foramen ovale. Okay, so before you're born, there's a little trap door that's open. You allow blood flow to go from the right side to the left side. It doesn't have to go through your lungs. You don't need oxygen in utero. As soon as you're born, that trap door closes because the pressures increase on the right side or the left side of the heart. Some people, that trap door is still open. And so there's an association with having that hole and migraines. And in fact, they did a trial over in Europe that looked at closing that hole in people with migraine headaches, classic migraines. This stuff first, it's called scintillating scotomata. It starts as this kind of wavy line that goes across your vision. That's the spasm to your optic arteries and stuff in the back of your head. And then you get this rush of blood that causes the 3-hour headache after. So what they did was they closed people's holes and found that 60% of people that had classic migraines actually had significant reduction or complete cessation of their migraines. And the idea is that your bowel produces, or the liver, or who knows what, produces serotonin. Serotonin is a vasospastic drug that would normally go to your lungs and get metabolized. The theory is at least it can cross over this hole, go to the head, cause spasm, and basically starts the classic migraine. So 60% of patients that had their holes closed didn't have migraines anymore, a significant reduction. They tried a trial in the US. We were involved with it at Allegheny General. The problem was you had to meet such strict criteria to get into the trial. You had to have so many episodes a month. You had to fail 3 meds. You had to be, and so they couldn't get enough patients enrolled in it. So it never got finished in the US. So closing that hole is not something that we're able to do. I can tell you selfishly, I had classic migraines. I never got the headaches, I just got the weird stuff. And I had a huge hole in my heart. And about 8 years ago, I had it closed, and I haven't had but 2 since then. I used to have once a week. I'd be in the middle of doing heart caths, and all of a sudden I get this stuff. And okay, maybe not the time. We're into it. Just give me 5 minutes. We're okay. And I've had literally 2 since then, 2 or 3 since then. But whether or not that's placebo, I could care less. It worked for me. I don't care. But that's the only association with migraines in the heart. Other migraines, you know, they come in all shapes and forms, migraines. And some people get diagnosed with migraines. They're not really migraines. It's very specific definitions of them. But treatment of migraines, sometimes people use beta blockers to sort of relax the blood vessels. Sometimes people use calcium channel blockers to prevent that initial spasm and then relaxation. I'm not a migraine guy, but the neurologists have pretty
But you
strict
couldn't have
definitions.
that operation because it's not approved.
Well, you have to have the hole, number one.